Hello Oncology residents. Welcome back to your own channel Oncology for Residents. In the last session, I showed you how to work up a case of oral cancer. I showed you history, physical examination, indirect laryngoscopy, direct laryngoscopy, biopsy, and examination under anesthesia. I intentionally did not talk about imaging in that video because I feel this is so important topic that it deserves a separate class. But you cannot interpret a CT scan or an MRI if you don't understand and visualize the anatomy well. This is where most residents make mistake. They directly jump to imaging without understanding basic anatomy and the pattern of spread of each tumor subsite. Let me tell you a fact. Head and neck cancer is one site in the entire body where anatomy is so important. It is such a compact region with extremely varied pattern of invasion and spread for the tumor at each site and each subsite. Also, there are numerous organs at risk embedded within this region. You cannot treat a patient if you have not understood the pattern of invasion of a tumor and various barriers a tumor has to face. We are going to move beyond the textbook today. We are going to learn the anatomy relevant for oncological perspective and how our knowledge of anatomy actually changes your decision making for treatment. Let's get started. Before we begin, for those who are new to this channel, I am Dr. Parveen Ahlawat. I am a consultant at Rajiv Gandhi Cancer Institute and Research Center in New Delhi over 12 years, and I have been practicing and teaching oncology for more than a decade. I completed my MBBS and DMRT from CMC Vellore, did my DNB at Rajiv Gandhi Cancer Institute and Research Center, pursued a fellowship at the Royal Marsden Hospital in London, and have later undergone specialized training on cyberknife from the United States. Are there any boundaries of oral cavity? Yes. Listen, the anterior boundary of oral cavity is very clear and evident. It starts from the vermilion border of lips. Vermilion border of lips, which is actually a junction of skin and mucosal surface of lips. The entire oral cavity and its subsites are behind this boundary. Is there any posterior boundary too? It is not so evident as the anterior boundary. You can imagine this as a complete circle behind your oral cavity. This circle starts from the circumvallate papilla on the dorsum surface of tongue inferiorly, goes laterally up along the right and left anterior tonsillar pillars on the either side, and joins the junction of hard and soft palate superiorly. So this is a complete circle. Everything behind this is oropharynx. Anything anterior to this is oral cavity. Today I am not going to give you a list of all the subsets of oral cavity. You have many textbooks for that. We are going to look at the anatomy of oral cavity through the eyes of an oncologist. We need to understand how specific barriers to tumor spread and specific pathways of tumor spread dictate exactly where a tumor goes and ultimately how we treat it. A mistake residents often make is thinking of oral cavity as a surface lining. It is not a surface. It is a complex 3D box. I am not going to just list the subsites. Instead, I will tell you the clinical significance of each subsite for oncological point of view. Every subsite we are going to discuss today has a specific pattern of spread and specific barrier to spread. If you understand the barriers, you understand the spread. If you miss the barrier, not only you miss the stage, but also leaves a residual disease despite doing a fantastic surgery. Let's break down the architecture of oral cavity. We start at the entrance, lips. For an oncological perspective, remember, we are talking about the vermilion border and the wet mucosa of lips. We are not talking about the skin portion of the lips. Skin is not a part of oral cavity. Any cancer arising from the skin will be treated as cutaneous cancer, not oral cavity cancer. The critical structure here is the muscle, orbicularis oris. Orbicularis oris. Why does this matter to oncologists? If a cancer infiltrates deep into this muscle, even if you cure the patient with surgery, this scarring causes microstomia. Microstomia is small and inadequate mouth opening. Think about the functional impact of microstomia. If you damage this muscle too much, the patient won't be able to put a spoon in his mouth. So, depth assessment here is literally a quality of life decision. Now, let us take a deep dive inside the oral cavity and look at the subsites of oral cavity in a very systematic way. We can start from anywhere, but let us move in anti-clockwise direction, from top to right and then down and then left and back to top. We will see in a systematic way. We will not see how textbook explains. So the first subsite is right upper gingiva. Next, right upper GB sulcus. Next, right buccal mucosa. Right retromolar trigon. Right lower GB sulcus. Lower gingivo-buccal sulcus. Right lower gingiva. Please notice there are two sides of gingiva. One towards the buccal mucosa, it is called buccal aspect or buccal surface of gingiva. The other is towards the tongue, called a lingual aspect or lingual surface of tongue. Then you come to the opposite side, left lower gingiva, one buccal aspect and the other lingual aspect. Left lower GB sulcus, left buccal mucosa, left RMT, left upper gingivo-buccal sulcus, left upper gingiva. Now we have three central or midline subsites. Oral tongue, we also call it anterior 2/3 of tongue. Then you have floor of mouth, a gutter-shaped region beneath the tongue. And third, superiorly, we have hard palate. So this is a complete circle of oral cavity subsites. If you understand it this way, you will be more clear. Then continuing posteriorly from the hard palate, we have soft palate, which is not a part of oral cavity. It is a part of oropharynx. You can also see some subsets of oropharynx in this image. You can see little bit of base of tongue, anterior tonsillar pillar, little bit of lateral and posterior pharyngeal wall, and of course entire soft palate and uvula. Now let us see and identify all the subsets of oral cavity in a CT scan coronal view. This is a puffed cheek CT scan of a normal person. We can start from anywhere, but let us move in the anti-clockwise direction. We will see in a systematic way. We will not see how textbook explain. I'll keep showing you subsites. Try if you can identify these subsites in this CT scan. Let me show you answers. The first subsite is hard palate. Then right upper gingiva. right upper gingivobuccal sulcus, right buccal mucosa, right retromolar trigon, right lower GB sulcus, right lower gingiva. Please notice there are two sides of gingiva. One toward the buccal mucosa called as buccal aspect or buccal surface of gingiva. The other is toward the tongue called a lingual aspect or lingual surface of gingiva. Then we have centralized structures. Floor of mouth on the right side, then oral tongue, then floor of mouth on the left side. Then you come opposite side, left lower gingiva, one buccal aspect and the other lingual aspect. Then left lower GB sulcus, left buccal mucosa, left RMT, left upper gingivobuccal sulcus, left upper gingiva. So this is a complete circle of oral cavity subsides. If you understand it this way, it will be easier for you. Then continuing posteriorly from hard palate, we have soft palate, which is not a part of oral cavity, it's a part of oropharynx. Now, I am going to explain you about subsides of oral cavity in a little bit more detail and their clinical relevance from oncological perspective. The first subside is the upper gingiva and upper GB sulcus in both sides. Have a look at this image. Here, there is a mucosa covering the upper alveolus. If there is a tumor over this gingival mucosa, there is a danger zone superiorly where you have maxillary bone and above which you have the maxillary sinus. A T3 or T4 tumor at the mucosa of gingiva and gingivobuccal sulcus region does not often stay in their sites for a long period of time. It starts eroding maxillary bone up, and then if further advances, it invades the maxillary sinus. Also remember, when you have an advanced tumor at this location, watch the nerves, specifically infraorbital nerve. If your patient complains of numbness on his cheek, the cancer has already climbed up that nerve. Next subsite is the buccal mucosa. This is a large surface area. Your barrier for a tumor located here is the buccinator muscle. Barrier for a tumor located in this region is the buccinator muscle. Once a cancer breaches that muscle, game over. The cancer gain access to subcutaneous fat and the skin. This is how you get these massive neglected tumors. Sometimes they progress to fungating masses visible from outside. It happens because the buccinator muscle has been breached. Now move all the way back to the gingiva. You encounter a region that is clinically very important subsite of oral cavity. The retromolar trigon, RMT. This triangular patch of mucosa behind the molar is a major staging checkpoint. Let us zoom in on the retromolar trigon. Anatomically, this looks like a harmless, small triangular patch of mucosa behind the last molar. But do not get fooled. This is a deceptive gateway. Look at the image on your screen. What is missing here? The barrier, the submucosa. In other parts of oral cavity, you have a nice layer of submucosa protecting the underlying structures. But here in RMT, there is no submucosa. The mucosa sits directly on the periosteum of the ascending rami of mandible. Mucosa sits directly on the periosteum of the ascending rami of mandible. Why is this clinically relevant? Because there is no safety net left now. A tumor arising from retromolar trigon doesn't need to be large to cause damage. It adheres to and invades the bone very early. Even a small T1, T2 lesion here often require mandibulectomy. Notice another important thing with regard to RMT. Look deeper. Laterally, you have masseter muscle, and medially, you have medial pterygoid muscle, a very important component of masticator space. The RMT is the entry point to this masticator space. RMT is the entry point to this masticator space because it is sitting right next to the medial pterygoid muscle. If your patient walks into OPD and has trismus, do not just assume it is pain. Check his RMT. Trismus usually means cancer has already breached the mucosa and invaded the medial pterygoid. That upgrades not only your staging, but it drastically complicates your surgery. Let us drop down to the lower gingiva. Here you have mucosa covering the mandible. We worry about two things here. One, high risk of bone erosion. If you have a small tumor sitting over the gingival mucosa, there is high chances of cortical bone erosion. Hence, you cannot just do a wide excision here and save the mandible. You often need a marginal or sometimes segmental mandibulectomy. Number two, the inferior alveolar nerve is at risk. Inferior alveolar nerve. Tumors arising from the lingual surface of gingiva mucosa can enter this nerve and travel completely invisibly all the way up to the base of skull. This is called perineural invasion. Always check for it. Now, the oral tongue, another very important subsite. There is a lot I have to say on this subsite. Keep in mind, we are talking about the oral tongue. It is also called as anterior 2/3 of tongue. We are not talking about the base of tongue, which is also called as posterior 1/3 of tongue. That is an oropharynx. This is a different disease and entity entirely. This is a sagittal view in which you are seeing tongue from the side. Now let us cut the tongue in half and look at it from the front, coronal view. These are the views you will look at most often on an MRI scans of your patient with tongue cancer. You are seeing 4 intrinsic muscles of the tongue: superior, transverse, vertical and inferior longitudinal muscles. You are seeing 4 extrinsic or deep muscles of the tongue: palatoglossus, styloglossus, genioglossus and hyoglossus. There are 2 more important muscles: geniohyoid muscles and mylohyoid muscles. Now, imagine a tumor sitting anywhere in tongue and look at it from oncological perspective. Do you notice something strange here? There is no barrier to tumor spread here. There is no fascia separating these muscles. These muscles are all interwoven. That is why we treat the tongue as a field. A tumor that looks like 2 centimeters on the surface can easily track another 1 or 2 centimeters deep along these muscles fiber without any resistance. Now look at the vertical white line right in the center in the coronal view, separating the left and right genioglossus muscles. This is called lingual septum. This fibrous wall is a good thing for oncological perspective because it acts as a temporary barrier. If a lateral border tongue cancer, T1 or T2, it usually respects this septum, sparing the other side. This allows the surgeon to do a hemiglossectomy, meaning removing half of the tongue. But if the tumor crosses this white line, the barrier is breached. Now you are looking at total glossectomy. This is a devastating surgery for speech and swallowing. Now look at that massive fan-shaped muscle taking up most of the space. This is called genioglossus. Genioglossus. It allows protrusion of our tongue. If a patient cannot stick his tongue out straight, or if it deviates to one side, it means the cancer has spread deeply. A cancer has deeply infiltrated this muscle. Now look at the sides, deep in the lateral groove between the muscles. This is where the lingual artery and hypoglossal nerve run. A deep ulcer here is dangerous. It can blow out the artery, causing a major bleed or paralyze the tongue. Now look at the bottommost muscles labeled mylohyoid. Mylohyoid. The mylohyoid is like a hammock. It is the strong bed that holds up the floor of mouth. Why do we care about mylohyoid? Because this muscle separates the oral cavity above from the neck below. If a tumor penetrates through the mylohyoid muscles, it is no longer just an oral cavity cancer. It has now directly invaded submental and submandibular space of the neck. So how does this tongue anatomy translate to clinical behavior? Look at this diagram. Think of tongue as a bag of muscles with no barriers. Cancers arising from the mucosa here do not just grow out, they grow in. They infiltrate the intrinsic muscles deeply. Look at the red tumor in the diagram. On the surface, it looks like a small lesion. But underneath, it is infiltrating deep into the muscle fibers. This is why palpation for tongue cancer has to be done very, very accurately. If you only measure the visible tumor, you will understage the patient. You must include the induration also in the tumor size. And this dictates our surgical rule. Because of this submucosal infiltration, we cannot just shell out the tumor. We need at least 1 centimeter margins all around the tumor in 3 dimensions. We have to take a cuff of normal muscle to ensure that we don't leave behind any microscopic disease. Lift the tongue up now. You see the floor of mouth. This is like a gutter. If a patient chews tobacco, gravity pulls the carcinogens to pool right here. Sometimes a tumor arising from mucosa of floor of mouth involves the submandibular duct or Watson duct. A tumor here can block those ducts. The patient presents with a lump in the neck. You might think it is a lymph node. Be careful. It might just be a swollen salivary gland secondary to obstruction. Do not mistake obstruction for metastasis. Look at the roof now, roof of oral cavity, the hard palate. This is a dome-shaped structure with a thin mucosa adherent directly to the palatal bone. Notice that even a small ulcer here can infiltrate the bone rapidly. There is simply no resistance for tumor to spread. The consequence is perforation. Advanced ulcer, if erodes palatal bone, may end up in oroenteral fistula, oroantral fistula. The patient will tell you, doctor, when I drink water, it comes out of my nose. That is the hallmark of hard palate perforation. With this, we finish all the subsets of oral cavity. There is one last thing with regard to anatomy I want you to be clear about. Listen carefully. Is there any boundary beyond which we can say this side is oral cavity and this side is oropharynx? Look at this image. I have drawn these these boundaries in a golden color here. This line defines the definitive border between oral cavity and oropharynx. This is an imaginary circle. Trace it from the hard palate and soft palate junction superiorly, moving laterally over the anterior tonsillar pillar down to the circumvallate papilla and back. Anything anterior to this golden line is the oral cavity, and posterior to this line is oropharynx. Look in the middle image. Anything anterior to the circumvallate papilla and anterior tonsillar pillar is oral cavity. Posterior to this is oropharynx. You see this image. Here also, the line is at the anterior tonsillar pillar. Why do we have to be so careful in deciding whether the tumor is in oral cavity or oropharynx side? Listen carefully. If the epicenter of a tumor is anterior to this line, it is an oral cancer. This is primarily a surgical disease. The main treatment modality for this site is surgery. If the epicenter of tumor is posterior to this line, it is an oropharyngeal tumor. That is often a radiation disease. The main treatment modality for most of the patient for tumor at this location is radiotherapy. You see how crossing this line changes the entire treatment modality. Okay, before we get lost in all these complex MRI and CT sequences in next video, let us just pause for a second. None of this radiology actually matters if you don't understand the basic anatomy of the oral cavity. Think of anatomy as your roadmap. I want you to keep 3 simple rules in your head when you look at these scans. First, depth. Depth matters. When you look inside a patient's mouth in the clinic, you are only seeing the tip of the iceberg. Just because a tumor looks small on the surface doesn't mean the actual tumor volume is small. A tiny ulcer on the tongue might be plunging way down deep into the muscles. You have to actively look for that infiltration, which is exactly why we rely on these images. Second, barriers define spread. Barriers define spread. Cancer is aggressive, sure, but it still bumps into physical walls. Structure like the jawbone, mandible, the maxilla, or thick muscles like the buccinator in the cheek acts as barriers. They physically force the cancer to change direction and dictate exactly where it is going to go next. If you know where those walls are, you can predict the cancer's path. Third, boundaries define your treatment. There are certain red lines in the head and neck cancer. If a tumor crosses what we sometimes call the golden circle, like crossing over midline of the tongue or creeping up into the skull base, your entire game plan changes instantly. You go from planning a straightforward surgery to suddenly facing a massive, life-threatening, life-altering operation, or maybe realizing surgery is not an option at all. So what is the big takeaway here? We have to stop looking at the mouth, oral cavity in two-dimensional. Effective staging means you have to train your brain to think in 3D. Always look beneath the surface. Trace out those hidden pathways before you ever finalize a treatment plan. Okay, now we have the anatomy down. We know the 3D roadmap. We know now the natural barriers, and we know the surgical red lines. But here is the real challenge you are going to face in the clinic. How do we actually see this roadmap in a living patient? You can't just look inside a patient's mouth and magically guess how deep a tumor plunges into the buccal mucosa, or whether it is secretly crawling up a nerve toward the base of skull. To see the invisible, you need the right tools. And that is exactly what we are going to tackle in our next video. Oral cancer, clinically relevant imaging. In the next session, we are going to take all of this anatomical theory we just talked about and apply it directly to the images. I'm going to cut through all the heavy radiology jargons and give you a highly practical evidence-based framework. I will show you exactly which CT scan and which MRI sequence to order, how to confidently measure the true depth of invasion, and how to track down those silent escape routes before you ever take a patient to OT or for radiotherapy. Trust me, once you see how this anatomy links up directly with the imaging, it is going to completely change the way you read your scans and how you make decisions in your clinical practice. Stay tuned. Signing off, Parveen Ahlawat.